3.
Welcome to the Rocky Mountain MS Center's special webinar series during the time of COVID-19. Today, May 28th, we'll be giving an update on COVID-19 and MS. This presentation features Dr. Enrique Alvarez. Dr. Alvarez is the clinic director at the Rocky Mountain MS Center at the University of Colorado. He's a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013. If you missed something on a slide, we will be archiving this webinar on our website, www.mscenter.org, so you can replay it at any time. We'll reserve some time at the end to answer questions from the audience. You can submit questions at any time by typing them into the chat window on your screen. We will answer as many questions as time allows. Today's presentation is for informational purposes only. Please note, we will only be answering questions relating to MS in this webinar. If you have general COVID-19 questions, please visit the CDC website. With that, we'll turn it over to Dr. Alvarez.
Well, thank you very much for the invitation to provide a little bit more of an update. It seems like the last few months have been update heavy, and that's just because things kind of keep changing. So I'll try to provide a little bit of information that's changed a little bit since last time and provide some updated numbers and things like that. And thank you very much for sending all the questions prior to this, and that kind of helped guide and put some of these slides together and information together. And then again, at the end, we'll be answering some questions. So we'll talk a little bit about numbers, this issue of flattening the curve, second wave, triple wave, quadruple wave. We'll see kind of where things kind of come out. A little bit update on reopening and what's maybe required to do that safely. We'll talk kind of a newer area that I added more information around is risk factors. Does MS, our disease, our drugs, et cetera, kind of count towards that? And then a little bit of update on testing and a couple slides on vaccines. So I think the big update today was that the U.S. hit 100,000 deaths. This is a very daunting number and kind of scary number for a disease that when we look back on it, we got our first report of it on December 31st. It's kind of crazy to look back on my in-basket and try to clean it out from months like January and February and seeing how little information there was or emails around COVID, and now it seems like about half my in-basket's related to COVID. So we've come a long way. I think we're understanding this a lot better than we did in the past, and I think our responses have helped a lot, and I think, you know, we can gradually kind of open up things safely. So what does that look like? So I'm going back to this website. The website's at the bottom. From IHME is an organization that looks at this. And I apologize here. It looks like the text got converted over to blue, so it's a little bit maybe harder to see. But I think hopefully you can see it. The social distancing in different places look at it differently, but it looks at things like how many cars are on the road, how much electricity use is going towards industrial plants, how much are we using our phones, and things like that. So a lot of really big data type analyses that allow us to kind of look at this. And at the height of things, sort of in early April, mid-April, we could see that in Colorado, we were able to socially distance about 60% according to this. If you look at some of the numbers from the Colorado Public Health Department, those numbers maybe reach into the mid-70s. And so again, you know, it's not a perfect science, so it's hard to measure, but definitely using kind of standard methods, I think with this, we can see that things really were able to, you know, get socially distanced. And I think it's important to realize some, you know, looking at this table, for example, that, you know, people started social distance before the government did anything about it. As things, got pushed out, it definitely helped support that. And then kind of at the opposite end, we start to see that people stop socially distancing quite as much before things even really started to reopen. You know, and so I've not been and done in restaurant dining yet, but apparently that I think opened up yesterday. Some of the national parks have started to open. Rocky Mountain National Park opens up next week, Wednesday. I think the regulations around staying within 10 miles of your house went away last week, Friday, in the state of Colorado. So a lot of these policies are really hard to measure a little bit because although we look at them at the state level, for example, April 27th was when Colorado loosened up some of its regulations. But for example, places like Denver and some of the metro area counties didn't do much of, didn't relax at the same rate and actually delayed it closer to May 8th. And so you can see here that the stay at order, you know, shows up as a little bit into May, but, you know, at the state level, it actually kind of went away a little bit before that. So it's a moving target, and for people studying the U.S. as a whole, you can imagine that that's even more complicated with all the states doing very different things. But it does give us a sense that, you know, even at this point, we're still doing a pretty good job of social distancing, and that it gives us a sense for, you know, why maybe we had such a nice effect on some of the latter data that I'll present. So one of the things that's come up a lot has been the use of face masks, and what kind of face mask, what are some of the precautions that we need to use. And this is a meme that I've seen sort of in different versions, but I think it illustrates the point grossly, but really well. And the reason of wearing a mask is it helps protect us some, but it helps protect others much better. So, you know, if you think about the urine test, if we all run around naked and someone pees on you, you get wet right away. If you're wearing pants, some people get on you through, but not as much as you're better protected. Some might bounce off and things like that. If you're the guy who pees is also wearing, if the guy who pees is also wearing pants, the pee stays with him and you do not get wet. So if you think about something almost as equally disgusting as spittle, when you're talking, there's a lot of little particles that come out of our mouth, and it does the same thing. It doesn't take much of a mask to really protect against, protecting other people from your spittle. And the really fancy masks are mostly to kind of help protect you from other people once those particles kind of get up in the air. So to me, it's interesting to think about this and how this has become a political issue. Finally watching the news a little bit yesterday and seeing some of our state politicians really kind of going after each other about the use of face masks or not using face masks. And although there are things that we can argue about, and I think the right thing to argue about would be how much we should be opening different businesses. Part of realizing that not wearing a mask and making arguments that other people need to take more risks doesn't make a lot of sense when they're playing with our lives, and that we really just need to be careful to protect and help protect others, much like you wouldn't sneeze on somebody's face when you had the flu, or other examples of this. And so I think let's argue about the important things. Let's argue about how much we should open, and let's do some of the things that we know definitely can help a lot of people that are not that intrusive and are really safe and cheap for us to be able to do. And this is the reason why we keep pushing face masks, washing your hands, some of these aspects. So one of the arguments I'm going to make is to get out of the house, enjoy the weather, walk around, when you're outside, a lot of the things that you can do are very safe to do because the virus and the environment gets inactivated by the UV light and things like that. And the challenges become much more so when we start to get around crowded environments. And that's part of the reason that led to having a little bit more slowed reopening of restaurants, for example. And these are the guidelines that came around for restaurants to open. Wear a mask. That gets hard while you're eating. So once you're eating, it's okay to take the mask off. Otherwise, I think it becomes a challenge. But you want the 6 feet. And there's nothing magic about 6 feet. But the idea is that when we do talk, the particles, the spittle that we form, doesn't travel much more than 6 feet. So there's a rationale for why these numbers exist. You also want to limit the number of people at the table because it limits the sharing of different utensils around the table and how many people you could potentially spread it to, and just the distancing and things like this. The 50% capacity. Some limits so that you can allow for people to be apart from each other and reduce the transmission of this. So I'm all in favor for these openings. Restaurants need to be open. It's a big industry in our world. Grocery stores need to be open. I think these are the things that we really want to see kind of open. We just need to be safe about how we do this again. So let's look at infections. So the real number of infections is the orange line at the bottom, the specific data for Colorado. And this is number of infections occurring. There is, and so the solid line is the confirmed, and then you see sort of this dotted line that represents the kind of estimated infections. And we can see that most people who get COVID do not actually even develop symptoms, but some people do. Then some people get really sick and have to be hospitalized. And some people get really, really sick, and those are the patients that sometimes when they get hospitalized have to be moved into an ICU and be intubated. And then you have sort of that next step, unfortunately, of death. And so let's look at some of these numbers a little bit more in detail. So here we can see that we actually probably already had a second wave that occurred sort of towards kind of the end of April, as you would expect as things started to open. So here I superimposed a little bit of the two graphs that we showed a little bit earlier, and you can see sort of that second peak happened about the same time as things opened up at the end of April and things. The good thing is we were able to hold off things at the hospital level. But let's look at the double peak. If we then superimpose, instead of the social openness, so here it's superimposed the number of deaths. And it's not to the same scale. So not everybody who gets infected is dying, but it helps highlight that there's, again, two peaks that we can see for deaths. And the time interval that happens between somebody getting infected and somebody unfortunately dying, we can see that it's somewhere between 2 to 3 weeks. So it gives us an idea of how long people, the time course for these infections. The great news when we look at this is how much that's dwindling down. This is a good, useful number to look at hospitalizations and the number of people that needed to be admitted to the hospital, the top line, and the bottom line admitted to the ICU. And you can see that top line is available beds in Colorado. The green line is number of ICU beds. You can see that there's a lot more beds than ICU beds. That's a good thing. And so we didn't come close to needing all the beds that we have available. But you can see that from an ICU perspective, we got close. We started using about half of our ICU resources as expected. And it's interesting at this point to superimpose what these models look like back when all this started in early April. And you can see that the resources that we thought we were going to need were much higher than what we actually had. And this was a huge concern and why the state shut down to some extent. Hospitals stopped doing a lot of surgeries with the idea that those ICU beds may not be available for those procedures, and so that we would need them for patients with COVID. And thankfully, that's not been the case. One of the things you can see is that the numbers without the opening, this flattening the curve, by January 1st, we'd be done. The numbers really kind of came down. By flattening the curve, it did push things out, but we can see that by July 1st and really August 1st, it looks like, according to these models, that things are probably going to be sort of much improved. Again, these are models and subject to change, as this example here highlights. And I think these models are helpful because they give us a sense of when things might return to normal a little bit better. And unfortunately, part of it is you have to kind of keep checking in to see where things go. And that, unfortunately, is, probably June is probably going to still require a fair amount of mask use and things like this, but maybe by July 1st, things can start to open up even more so for the summer. Hopefully the pools open up for the kids and those kinds of things. So this is a lot of models. Let's look at the actual numbers. And I think the beauty about this is that we can start to see that the number of patients getting sick in Colorado has really started to drop off. There's an area of gray on the right side. So even though the numbers drop there to almost nothing, just remember that a lot of that is, there's data still coming in and hasn't been collected. So a little bit of hesitation. So I would probably concentrate on the numbers to the left of that gray area. But you can still see very clearly that the numbers have dropped really pretty significantly to well over below half of where we were at only what seems like, a month and a half ago, a couple of weeks ago. So the number of cases is going down. This is showing for hospitalizations itself. I would ignore kind of the yellow-orange bar. That represents patients as they get tested and are suspected to have COVID but haven't been confirmed yet. But look, and so early on, there was a lot of those cases until testing kind of came on board a lot better. We have really good testing, and the turning around now is usually within hours. The blue bar represents sort of the confirmed hospitalization, so let's concentrate on that. And again, you can see that at one peak, we had almost 900 patients across the state, and we're down to about 362, so almost a third of where we were at in the past. The number of new admissions you can see on a daily basis, is way, way down as well. So I think this provides us some really good ideas that those measures of distancing worked, and that the numbers are still coming down. And as things opened up now 3 weeks ago, that it was appropriate to open up things as they were. This is a very similar graph to showing the University of Colorado Hospital numbers. The bottom part, the lighter color is hospital beds. The top part is ICU beds. You can see that early, a lot of the patients being hospitalized were ICU patients, so people were waiting to get really sick before they came into the hospitals. And as things have opened up, I think a sense of another key point that I'd like to highlight today is that the hospitals really are safe. And so you're starting to see that the proportion of patients in the hospitals now are less sick than they used to be, not requiring the ICU for their admissions. The cases in the middle, those little kind of transition areas, are just the patients that are getting further testing. As we look at this next slide, this is the number of deaths in Colorado. And again, a little bit of hesitation kind of in the last week, just because the numbers are simply probably not in or recorded. But here we can see that, on a daily average of getting 35 or hearing about 35 deaths a day, that we are probably down into the easily single digits and probably a lot less than, kind of closer to about less than 5 cases a day now. And so again, very reassuring numbers at this point for the number of cases. All right, so numbers are coming down. That's fantastic. Let's talk about risks and comorbidities. And this is not something I've highlighted before, so this is a little bit of a newer area. So if that was kind of putting you to sleep, hopefully this will help you wake up a little bit. So who is at risk? All right, I have MS and I'm immunosuppressed, but the number one risk factor that I'm going to keep highlighting today is age. Here you can see that these are the bars broken up by age. And you can see very few cases sort of below the age of 20. And then as you kind of get into older groups, you can see that there's more and more cases. But the part that I'm going to highlight is the blue area. The light blue is being hospitalized. And you can see that as you get into the right group, those over the age of 80, that well over 50% of the patients were over the age of 80. If they developed COVID, were requiring a hospitalization. And almost a third of them, if not more, were dying from COVID. The mortality rate is really high if you're 80s and older. It is still significant in your 70s. So that's still a pretty high percentage, but most patients, again, did not require hospitalization. As you get into the 60s, the number of patients who required hospitalization really starts to drop off, and you start to look at the number of deaths, again, really, really dropping off. So as an MS patient, you have to kind of consider your age and determine, from there, how safe is it to interact with other people and things like that. Let's look at other comorbidities. So by far, the big one that's coming out is cardiovascular disease. So here are two tables. On the left is the Chinese CDC data. This is a little bit older. I think this was from end of February, but remember China got hit with this a lot earlier. And on the right is data from Italy. And what you can see is that ischemic heart disease, AFib, all those are, cardiovascular things, that a lot of the patients who died had these as risk factors. 33% plus, if you include sort of all the, different places are going to report it somewhat differently, versus, 10% in the Chinese group. But clearly, far and away, heart failure is a big risk factor for death in COVID patients. And this is not MS data, but it gives you a sense for things to that were popping up, right? We don't see MS on this list or things like this, but some of that is just the low numbers of MS patients in the population. Chronic other conditions that really popped up, although diabetes is up there. We have to consider how well the diabetes is controlled, and I think that's one of the things that we can kind of control a little bit better. Chronic respiratories, especially things like COPD, still account for a big chunk of patients who died. And so what you can see on the Chinese data, that bottom line is, had no risk factors, is there was less than 1% who did not have any risk factors who died. On the right side for the Italian group, very similar number. 3 patients died who did not have any of these risk factors. So if you're somebody who's young, who doesn't have many of these risk factors, I think it gives you a lot of confidence of saying not to go out and get it on purpose, but some reassurance of saying, hey, I can probably go out and it wouldn't be the end of the world. As you start to accumulate comorbidities and you have more severe versions of these and you're older, you can see at the bottom that, as you start to look at 3 comorbidities in that bottom row on the right, that almost 50% of those patients started dying from the disease. So I think this helps put in context other comorbidities besides MS, being on immunosuppressives or things like that. The CDC guidelines do mention immunosuppression. They do mention rituximab. Rituximab is very similar to ocrelizumab. And so what's the risk associated with that? And I could not find those kinds of medicines on any of these charts, and my suspicion for that is that the risks were really low for being on those medicines. So where can we gather data? One of the best ways for me has been to actually listen in, and I've mentioned these in prior calls. There's an international women's group in MS, and they've highlighted data from different countries. Overall, and to kind of give you the punchline, is the risks do not appear to be higher in MS patients, and the outcomes on any of the drugs that we have do not appear to be worse than for patients not on those drugs. So what is some of that data? So this is the American registry. I apologize a little bit for the small font, but this is data as of this morning. So they've had 227 patients confirmed with MS, and that by and large made the big percentage of patients being reported. You see a little scattering of NMO, MOG, and other versions of conditions that we would now kind of think of kind of going into MS. Of these, there's been 13 deaths described. And so what can we learn about these 13 deaths that have occurred in the U.S.? So here's a little bit of data around what these patients look like. About 80% in the United States have been confirmed cases, and that's a much higher percentage than you would see from repositories elsewhere in Europe or in other parts of the world. In the U.S. data set here, which you can see is that for the 13 patients that died on the sort of middle column or the left column for data, versus on the right side data that for the other patients that are still alive. And I think it's very instructive to kind of highlight some of these things. So of the patients that are alive, 75%, the number in parentheses, are female on the second row there. But if you see it, the number that are dying, it's only about 38%. So the number of cases is about the same in women as in men, but we see that for men, it's a much higher risk of dying from COVID. So that's another risk factor. You can see age and the big difference. So for patients who are surviving COVID, the average age is 48.2. Those that are deceased, 66. That the duration of disease activity tends to be higher for those patients that are dying. As far as types of MS, you can see that that's pretty similar, and the numbers outside of MS are really small, so I'm going to skip a lot of that. But if you go down into clinical course, again, what jumps out to me is the primary progressive and secondary progressive and how much higher as a percentage those are within the disease group. Why is that? Usually because they tend to be more disabled and older patients, because when you're younger, you tend to start off more relapsing remitting. So is it something related to just the type of MS that you have, or is it that age factor? And to me, I think a lot of it is age. Level of disability, probably, again, a huge factor for that. So I think it's less the type of MS and more the age and the level of disability. So you can see that 61.5% of patients who died were non-ambulatory. These are probably patients that are not going to be going out much, and it probably represents the concerns that we've had about the risks of COVID going through nursing home facilities and rehab facilities throughout the country, really internationally. So this gives us a picture of that. As you look at the comorbidities within the United States, you can see that those 11 out of 13 patients had some comorbidity. So almost nearly 85% versus only 46% really for those that are alive. So these comorbidities matter. You can see cancer doesn't particularly jump out. It jumps out in other groups. Cardiovascular disease, huge difference between these two groups. As you go down the list, you can see a little bit of kidney disease. Again, a lot of these are just really small numbers. Diabetes comes up a little bit, and you start to have some reasonable numbers. High blood pressure kind of can be debated some, but here clearly puts us a little bit higher risk independently. And some of this will have to be analyzed because as you get older, the chances of having hypertension goes up. So some of these are definitely complicated or confounded risk factors. Let's look at drugs. And this is the one where we don't really see much difference. You can go down the list of patients. Actually, ocrelizumab falls under 15% who died. For those that are still alive, it's at 30% to compare percent. So half as risky, if you want to say. It starts to bring up the question, are some of these drugs protective? And, I think that might be a push as well. Some of the people that aren't doing as well may not get reported as well. But I think the important part about this is that it highlights that we should not jump to the conclusion that these drugs are worsening things. When we look at the last line, none, you can see that overall there's a lot more patients that are not on treatment that died than patients who are actually alive. So not, again, you probably should be on treatment, but if not, don't start treatment because of COVID. But to highlight the fact that, things like Gilenya have been looked at as far as treating COVID, for example. I kept this slide in. Unfortunately, I did not get a chance to update it within the numbers at the Rocky Mountain MS Center at the University of Colorado. So this data is the same data I presented a few weeks ago. We've had 3 deaths, one in MS, one in NMO, and one in autoimmune encephalitis. This number, I can tell you, has not changed. So we still are at 3 deaths. Some of the other information as far as number of patients with confirmed COVID has gone up. But as far as the death numbers, I can tell you those are exactly the same as it used to be. And again, I would go with data from the other repository because it has more numbers, and I think it's a lot safer to look at it that way. Because we do use so much of the B-cell directed therapies, both rituximab and ocrelizumab, the one death that we had in MS was ocrelizumab. Is that coincidence? Is it not? Well, we can start to look at another paper that just got published, became available on the 16th of May, and this is data from Roche looking at 100 patients reported to them. So far, no deaths within that group, but again, that's partly because we had not reported our death because that happened not that long ago, and just trying to get the data in. But you can see that 5% of them were in kind of critical condition, and again, that fits with the numbers that we're seeing across the board, actually maybe on the low side of things. So numbers are starting to get published, and they appear reassuring for some of these treatments. I'm going to turn over to data from Sweden, and the reason for this is 1/3 of patients in Sweden are being treated with rituximab. That seems like a really high number when you talk to most people in the United States. At the Rocky Mountain MS Center, that number is actually closer to 2/3 or 3/4. So it's probably the closest large registry that we have to what our practice is. So when you look at the bottom line, natalizumab or Tysabri, they still use a little bit of this drug. It's about 6.6% versus the 33%. And what you can see is, as you look at these numbers, they do report what looks to be that some more patients on rituximab appear to get bad outcomes. So if you start to look at it, the number from that 33% goes up to 56% of all the patients that were hospitalized, 75% of those patients that were in the ICU. For natalizumab, the 6.6% becomes 12.5% for admission into the ICU. Again, if you try to correct for EDSS and age, these numbers don't quite correct out. So it does bring up the question is, do you see some worse outcomes on these medicines? But again, it doesn't appear to be the case. And if you do the statistics, it doesn't come out to be statistically significant, mostly because of just the few numbers and that were in the ICU. They did not present deaths, and I suspect that's just because the number was probably really small numbers, if any. but it gives us some reassurance in that perspective. I put this busy slide that I copied from them. If you go to the third bullet point, it talks about 1/1000th of Swedish MS patients were hospitalized due to COVID. I think that's an important number because this is a whole country registry, and the way their socialized medicine works is they have access to pretty much every MS patient in their country. And so the fact that in Sweden, where they use a lot of the same drugs, only 1 in 1,000 patients were getting hospitalized. That's about what the rate is for non-MS patients. So when we say MS does not seem to be either protective, that was one of the other questions that came up, was MS protective because of the heightened immune system? It doesn't appear to be that. People with MS are still getting COVID. And then 1 in 500 Swedish MS patients on rituximab were hospitalized due to COVID. So the number goes up a little bit, but it doesn't appear to go up much. And one of the things that they really highlighted is this ascertainment bias. What I mean by that is when you have a patient on these medicines, because of our concern about using these medicines and whether or not that maybe makes it worse, we're more likely to report these patients than if they were not on those medicines. And so some further data needs to come in and be analyzed. But at this point, the takeaway point is that it does not appear that we're seeing a big difference in patients on rituximab. And again, kind of similar effect as ocrelizumab. I bring up Sweden as an example, too, of a country that has not socially distanced much. And that's kind of a full statement in the sense that Sweden did not pass a lot of regulations to socially distance themselves. However, Sweden probably socially distanced a lot more than many other countries simply voluntarily. People just were still not going out to restaurants and doing things. The restaurants were open, but their occupancy was really low. And yet Sweden has some of the highest rates of COVID within the Scandinavian countries. But again, it still doesn't match up with what we saw sort of in Southern Europe. And some of that has to be just with the population density and things like that. So using real numbers, we can see that there's a concern about these medicines, but that these medicines don't appear to be causing an extra concern about this. This drove a lot of our decision at the University of Colorado as far as our guidelines. So at the beginning, we had the same concerns, and that explains a little bit why our initial guideline was to push out infusions. I want to highlight, because of some of the safety aspects and having now some data around it, that we felt pretty comfortable with continuing the infusions on a regular schedule. And so we have proceeded with having people return to a schedule, and people should start their treatments, especially if they were not on treatment, or switch if they needed to be switched for having disease activity, not tolerant their other drugs, and to get back on a regular schedule for their infusions. Again, we try to make decisions based on data, and as we get data, we started to change our thinking about that. To get back into some theoretical thinking, if we think about COVID as 3 different diseases, kind of the early infection, kind of upper respiratory, the pulmonary phase, or kind of more lower respiratory, more lung disease, and then stage 3, or sort of this period of hyperinflation. So the immune system is trying to attack the virus and start to get really ramped up. This we call sometimes ARDS, acute respiratory distress syndrome. This is what lands a lot of patients in the ICU into the ICU, because there's so much inflammation in their lungs that the patients can't get air into to breathe. So I showed this slide last time, and presented the idea that as you think about that very bottom line is, maybe at the beginning we want to avoid some of that immunosuppression, but as you get into the latter stages, that's where immunosuppression might be helpful. The timing of this stuff is always a little bit hard. it's interesting to kind of think about this slide still showing hydroxychloroquine and chloroquine, and again, no political statement, but to highlight the fact that, especially in older individuals, hydroxychloroquine appears to be toxic, and there's actually more deaths in patients treated with hydroxychloroquine than in patients not treated with hydroxychloroquine. And so, I would avoid thinking about those medicines. Remdesivir is a drug that actually came out from Ebola and actually starting to have some okay data at trying to reduce the days where people have symptoms and the mortality rate associated with it. All right, so from the theoretical, let's put a little bit of data. So this is in the UK. I think they meant to say ICU admissions. So intensive care unit, it might be intensive treatment units in the UK for their name for it. This is a series of slides presented by Gavin Giovannoni, who is an MS provider in the UK. And there they had severe COVID cases on the left and kind of similar for viral pneumonia on the right, the black viral pneumonia. And what we can see is that fewer percent of patients who are immunosuppressed ended up in an ICU due to COVID than they did for viral pneumonia. So at least in COVID, again, it highlights a little bit that it's either less of a worse disease, or that at least it appears to be beneficial to be on immunosuppression as far as trying to avoid the ICU. So a little bit of the reassuring data. IL-6 is a cytokine, that's the IL-6 in the middle there, that really seems to be driving the inflammation in COVID infections. One of the big drugs that we're using is a drug that inhibits IL-6, the ocrelizumab, and several other drugs are being studied in the treatment of COVID. And you can see that B cells make IL-6, and IL-6 itself appears to stimulate those B cells and make more antibodies. Those are highlighted there in red boxes towards the left of the figure. So if we take out those B cells, you're going to end up with a little bit less of the IL-6 and a little bit less on the antibody production side of things. All right, so what other possible reassuring data that we have? So another name for COVID-19 is the SARS-CoV-2. So this is looking at an Australian study. And sorry, this is a very heavy data slide. I wish I had a pointer, but on the left side, you can see that the immunity, the number of virus particles, basically the blue line drops down to below 45 there, below something that we can detect, and matches all the other lines, so that by day 7, the amount of antibody is basically non-existent, meaning the body took care of the infection most of the times within 7 days, and particularly in these patients. If you look at the figures on the right, and especially the top, we can see that at day 7, there's really no antibody to COVID. This does not start to happen until day 8 and day 9. So that these antibodies, we can say, are probably not the antibodies that are helping you recover from infection. Meanwhile, what we can see is that, what it suggested from other SARS-CoV-1, so kind of the earlier version of this, that apparently some of the other types of T cells appear to be much more responsible for preventing this. As we look at 2 patients who got reported here who do not have any B cells, we were able to see that these patients actually were able to clear the COVID infection. So these patients had absolutely 0 B cells. So these are patients surviving on antibodies given to them by other people and things like this, but have no B cells at all, and yet they were able to recover from COVID. So this provides us a sense that we don't need the B cells in order to be able to fight out COVID. So this is the last theoretical speak to kind of say that between the data that we see in this, that it appears that these medicines are probably going to be okay with COVID, and that patients will bounce back from this. So we are opening up at CU. We started this at the end of April. We're gradually returning to a new normal. We do expect that long term, about a quarter to maybe 50% of our visits will still be via telehealth. Probably be emphasizing in-person visits that are new, and some return visits where new symptoms are being developed. It looks like the figure in the right quarter basically disappeared on us for these slides, but the highlight there was to emphasize that the hospitals are safe, and it discussed that the air is filtered, that there's distancing happening at the hospital, that patients are being required, as well as providers, to wear masks, and more importantly, that patients with COVID are being treated in different areas than the areas where we're seeing patients in clinic. If you do come into clinic, make the most out of it, bring your records and MRI. Wear your own mask. If not, the ones will be provided to you. That's a new aspect since last time. I'm going to touch base quickly on testing. This has not changed much. So the RT-PCR is the PCR test that happens to look for active infection. So only if the virus is there can it be picked up. Once you clear the infection, you're not going to be able to pick up you end up with a negative test. We can now test pretty much anybody that we want for that. On the serology testing, the important part about this is, yes, now we have it available at UC Health. These results are turning around within 6 hours, which is fabulous. There's questions around sensitivity. How good are you going to pick it up if somebody has those antibodies? The FDA goal is 90%. The test at University of Colorado is 97%. Specificity refers to if you get a positive test, what are the chances that you actually have the antibodies? This becomes really important for diseases where not a lot of people have it, because if you end up with, on average, only having 2 or 3% of the population having the virus, but you have 5% rate, so that 95% specificity means that 5% of patients are going to get a false positive test. That's over twice as much as the patients, or around twice as many patients who are going to think they're positive on their antibody test due to a bad test than who actually probably have the disease. So not very good testing. The test at the university is said to be greater than 99%, and actually the number I'm hearing is something like 99.7%. There's also a test that's being looked at that actually looks at antibodies to 2 different proteins. So if you do 99% times 99% by looking at basically 2 different tests, that number is going to get really, really, really good. And that test is still being developed, but I'm hearing it's getting close. The big point about this is that the antibodies may not tell you that you're protected. So as we saw from before, from that Australian study, those antibodies took longer than what it took for you to clear the infection. So just because you have a positive test doesn't mean that you're protected, and that you still maybe need to watch out for it. So when do we want to use the test? It's still up in the air a lot. The main test, the main use for the test right now is to look for people whose blood we can collect to give it to other patients who are sick, with the idea that hopefully those antibodies could be protective. There is some suggestion that these antibodies are protective. There's data looking at some of this convalescent plasma, there's blood from patients who are recovering from disease that appears to be protective. Another aspect of the test is what antibodies is picking it up. So there's IgMs, which happens early, and IgG, which happens a little bit later. But these tests are not positive for days, and probably not positive for a good week after you are after you're sick. So this is not the test to do if you think you have COVID. This is a test to kind of see if you cleared it in the past. Let's talk about vaccines real briefly, and we're coming to an end here. There's many different types of vaccines. I'm not going to go through this, but there's inactivated vaccines or killed vaccines. On the right top, there's live attenuated vaccines. These are the virus vaccines that we've we'd like to avoid in most of our MS patients, particularly if you're on certain treatments, immunosuppressive treatments. So this brings up the question of, how safe will vaccines be for our patients and things like this. That we like sort of more simple vaccines where you can't get the infection from it, that maybe involve just making an antibody to it. I think the most interesting ones that are coming out are these nucleic acids, so on the bottom left, that are RNA or DNA based. These are in clinical trials. There's no vaccines like them out there quite yet. But this is probably going to be sort of the first series of vaccines to come up in the COVID era, because you can see that these RNA and DNA vaccines take the least amount of time to develop. So that's that kind of first arrow. These happen much quicker. You can see sort of how some of the different types of vaccines take longer to develop. And the reassuring part, to some extent for our patients, is that the ones that take the longest to develop are the live attenuated, which is the ones that we want to try and avoid. And it's also because, to some extent, COVID is has such a high rate of infectivity, and that there's no cure for it yet, and things like this. The facilities to grow the virus to make it attenuated would have to be very careful, making it almost probably impossible to try and develop these types of vaccines. So I don't think that the type of vaccines that we're going to get are going to be live attenuated vaccines. So more to come on this. There's over 10 vaccines now being tested in humans, and over 100 vaccines are being tested in some shape or another. So it's impressive how fast this has moved in anything related to medicine. That's impressive numbers. So I think we will have vaccines, and the timeline, again, remains a little bit hard to know when that's going to look like. I do suspect it's probably going to be closer to 2021 than anything this year. So for conclusions, COVID cases have come down dramatically. Social separation has been effective. Relaxation is likely safe, but we have to look at comorbidities and other things and proceed with caution. If I'm going to highlight anything, is we have to get out of the house safely. So I emphasize this part. You still have to wear masks. You have to wash your hands. You have to do all those things. Keeping your mental health, the wellness part, is super important. I want you exercising, eating right, and overall just being well. MS patients, even on immunosuppression, do not appear to be at any increased risks. Hospitals are safe. We're proceeding with infusions as before. Just as we're ramping up, the things that we're pushing out are just kind of routine MRIs. There's no timeline to get a lot of these things done, and if it helps kind of allow for extra cleaning between MRIs, that's what we're hoping for. Bring a mask, bring your records, try and maximize those visits. And then with that, Kelsey, I'll turn it back over to you and see if we can answer some of the questions.
Excellent. Thank you so much. If you have a question to submit, you can do so using the chat window. We're unable to give specific medical advice out during the webinar. If you have questions relating to a specific treatment plan, please discuss those with your neurologist. I encourage you also to check out the COVID-19 education page on mscenter.org. There's a banner right at the top of mscenter.org. You can access Dr. Alvarez's past webinars with COVID information, and also a webinar featuring social worker Alyssa Berlinger discussing how to manage mental health during times of uncertainty, a webinar featuring Emily Nelson on the importance of leisure during COVID-19, telehealth tips, and a resource guide that includes links for everything from COVID information, food and supply resources, mental and physical health links, and a wide variety of fun and unique entertainment activities that are pretty much all free. As we move through the questions today, in the interest of time, I am not going to repeat questions that Dr. Alvarez has already covered. If you have questions about the state of COVID in Colorado, look for the recording when this comes out, and you can replay parts of that. And I'll be grouping questions that are similar. So let's talk a little bit about daily activities. We've had a couple of questions. Is there a best type of mask to wear? Are there special recommendations for people who are high risk going forward as things open up? Things like haircuts, having cleaning people come to the house, restaurant guidelines, kind of just a general daily life now.
Yeah, so something is better than nothing. And then as far as, specific types within that, so one of the things you're looking at is number of layers of cloth, for example. So you want to have some more filtering rather than less filtering. But honestly, you want a mask that is comfortable, because if it's not comfortable, then you're not going to wear it. So I think the important point is something that you will wear. If you wear glasses, we know the challenges around sort of fogging up glasses and things like this. Usually they talk about sort of having 3 layers. That's the only difference that really comes out between sort of the surgical masks and the other types of masks. So nothing too specific there. I think the biggest aspect about it is not touching your face, and any mask tends to do that because it tends to make us aware of, oh yeah, I have a mask, and I probably shouldn't touch my face. I think that's almost as important as anything else out there. What was the second part? Sorry, Kelsey.
Kind of interacting with people. We've had a couple of questions about like getting haircuts, having people come in and assist in the home.
Yeah, so I think a lot of that, again, you have to look at yourself and where you fall under the risk category. So if, as the numbers have started to come down, I think it starts to allow us to feel much more comfortable doing those kinds of things and going to these places. I would look for places that are particularly adhering to all the guidelines, who limit the number of people that are at the shop, who are cleaning in between all the different haircuts, that are wearing masks, that require you to wear a mask. I think those are the best predictors and best things to guarantee of any spread. It's going to be the same rules around restaurants as people coming into your house. If they're adhering to the rules, they're probably going to be conscientious people who, if they have symptoms that are concerning for COVID, will stay out of other people's ways. If they're not wearing a mask, I truly believe they're being selfish, not paying attention to other people. And then those are people you probably don't need to be around.
Looking at folks who have MS and have had COVID, questions like, is it safe to go ahead with Ocrevus infusions after COVID? Do you have any suggestions for if an antibody test is positive for COVID?
Yeah, so if you have already gotten COVID, congratulations in getting past it. And it's unclear how protected you are from another infection, but it does look like with this group of viruses, the common cold and other things like this, that you do get protection at least for up to a year. So you may not be protected for forever, but at least you're going to be in a really kind of nice, comfortable place for the next, several months, year, and potentially even longer. So the guidelines that we've always used, whether it's COVID or other types of things, I don't care if it's flu or whatever, is that if you have a fever, a cough, runny nose, don't feel well, things like this, you don't get infused. If you're starting to kind of feel better and have kind of cleared it, then you're fine to get your infusion. I think that's the important step. We want you to have your infusions on a day where you're not having any symptoms. If you're having symptoms, put it off. The antibody test tells you that you've cleared it, and apparently you've mounted a good enough response to push it. Some interesting numbers I didn't quite mention was that there's been a push at the hospital to test most healthcare providers. And so far, the chances of becoming positive for kind of the frontline workers at the hospital has been about 2 to 3%. So most people out there have still not gotten the virus. But I do think that our test at the university is a very good test.
Do you think that being on Ocrevus would have any impact on the results of the antibody tests?
Repeat that one more time, sorry, Kelsey.
Do you think that being on Ocrevus or any particular DMT would impact the result of the antibody test?
Yeah, so so the backstory on this question a little bit is that if you do have, if you have eliminated those B cells, they're not going to make the types of cells that might make antibodies. We have seen with other types of vaccines that, for example, the flu and things like this, that being on B cell directed therapies, that you may not mount as good of an immune response as you would have otherwise. With that being said, it may decrease the chances of having a positive antibody test, but it's really hard to know at this point, you know, by how much that's affected. We just don't have those numbers to provide any real great guidance around it. The whole utility of whether you, what would it mean if you've had a positive antibody test is still to be determined. That, you know, it's not like if you have an antibody test that's positive that you would go out and start, you know, hugging somebody who has active COVID without any protection or anything else like that. So, you know, it gives us a little bit of peace of mind, and kind of, I think it helps, you know, sort of answer that question. Oh, I wonder if that snuffy nose I had, you know, 3 weeks ago was COVID. You know, it helps answer that question. But clinically, I would not recommend that it change our behavior much. I still want you washing your hands, wearing your mask, and things like that. Again, what we're seeing with most MS patients is not to take any extra precautions because of immunosuppression and having MS. Having other comorbidities, bad heart failure, bad COPD, uncontrolled diabetes, that's going to be the kind of stuff that's going to increasingly tell me, you know, to suggest to you to stay away and stay at home.
And what are the steps that someone with MS should take if they start having COVID symptoms? Would they need to call their neurologist, go to an ER?
Yeah, so great question. I think it depends a little bit on how bad your symptoms are. So if you have the sniffles a little bit and you're doing okay, and a little bit of fever, you know, trying to control it at home, those kinds of things. You don't necessarily need to seek medical care for that. It is good to know around testing, just, you know, if you're around other people and things like this and concerns for that. Again, by the time you're showing symptoms, you've probably spread it to the people around you in a household environment, but at least it gives you a warning about whether you need to, those people, if they get sick, if they need to worry about it or not. Then contacting somebody, you know, within MS care, a lot of times neurologists, you know, are providing a lot of primary care type services. But whether it's primary care or neurologists, we can all order the testing. Once you have an order through somebody at UC Health, then you can go through one of the drive-by facilities. If you're not one of the patients seen at UC Health, you know, just touch base with your primary care and where they're doing testing, how long does that testing take to come back, things like that become important to know. Where can you get tested? So through the UC Health system, there's at least 2 in the metro area that have drive-through capacity. And there's also locations up north and down south in Fort Collins and in Colorado Springs where you can get tested. So, but I know Kaiser has a lot of testing that they're doing as well, and most other systems can do it. Most of the private labs can do it. So Quest, LabCorp have their own COVID testing. So there's a lot of testing everywhere right now. But you know, depending on the symptoms, you may need to go to the ER if you have a fever and you can't break the fever or things like this. You know, you have to kind of treat it almost kind of like, think about it as the flu. You know, if you can hang it out at home and just kind of treat it with some chicken soup, great. If you need a little bit more than that, you know, then at that point is where you want to start reaching out. We always appreciate a note to kind of say, hey, you know, even if it's an FYI, you can send it through My Health Connection to us, or you know, give us a call and say, hey, I got tested for COVID and I was positive. You know, then we can kind of keep track of the numbers and follow and try to see where we're at with our numbers. We do contribute cases to that U.S. registry, so having some of that information is helpful.
Would you suggest a person that doesn't have any symptoms get tested?
Definitely not for the PCR. I think the big one becomes for the antibody. And honestly, I struggle. I mean, as one of the healthcare providers, I got my notification that my test has been ordered up by the healthcare system. And I don't know if it's worth it for me to go in and get tested at this point. I still am struggling with that. I know the hospital would like to have that data. So I'll probably will do the testing so that they know other providers who, kind of the protections that the hospital was employing. Were they good enough? Do they need to be better? Those kinds of things. So it's helpful data, and that's why they're trying to do that. But, on the selfish side, for me to get stuck for blood, I'm not necessarily a huge fan of needles. I think probably like everybody else. And so trying to see what I would use that for. If I cleared an infection, great. I'm still going to wear my mask and try and protect others and things like that. So, so I don't know that people need to go out and get tested if they don't have symptoms.
And I have just two more, I think, quick questions to end with. On the number of death graph that you showed, there were several times where there was kind of a peak and then followed by a drastic drop and then a return back to the normal curve. What explains those?
Yeah, so social data. So this is kind of the data that we're looking at is messy data. And you saw in some of the graphs that they average things over 3 days just to kind of help smooth out peaks. It's interesting when you look at sort of the case reports, you will see dips for the weekends. That happen a lot. So I think some of that data is just the noise of the data. I do think that there was a peak, a second peak that did happen when things started to open up a little bit, which, was fine because it didn't become a huge peak. It just, there was a little bit of a bounce back and that got smoothed out a little bit sort of on hospitalization numbers and death numbers and things like that. Some of that second peak was made a little bit more drastic by probably some rule changes about what consisted a COVID death. So, kind of getting into the nitty gritty of the data made it a little bit more messy. But I think that it helps highlight, that we kind of need to see more patterns and that a day here or there is not very useful. And so trying to see patterns over a week or two versus kind of, oh, the numbers went down. Oh, yeah, it was just a weekend thing becomes important to kind of realize.
And then we had just a couple of questions come in after your conclusion, kind of more specific social distancing questions. So I just wanted to pose them. People are wanting to see their family members and wondering about like grandchildren who attend daycare. Just kind of go over that part one more time.
Yeah, so I think the important point is, so usually if you're thinking about daycares, you're somebody still in your 30s, 40s with young kids, and we've discussed how low the risks are. Most MS patients on these drugs tend to be on the younger side. And so then things like going to restaurants, going out and doing a lot of these other activities, I think that's why we want to try and get back to sort of a normal sense of activity. That whatever this new normal becomes after this, that's kind of, I think, the main goal that we want to go to. So the thing to adjust for is sort of the levels of comorbidities, those kinds of things. I think maybe one of these, I talked about my dad. My dad, I think I have him on permanent lockdown. I have a lot of concerns for him. He's got bad COPD and heart failure. His diabetes is not that well controlled. Doesn't have MS. So for him, I'm almost in a sense locking him up in the basement. I think that you have to look at the whole spectrum of things We also need to look into people, and the emphasis, and I know that this created confusion a little bit after the Ed Summit, so I apologize for that. So I think this is a great way maybe to end, unless there's other questions, but this notion of when I'm saying get out, do things, try to take care of you mentally, so that you don't get cooped up at the house. That's the point of getting out of the house. Is we want you healthy, we want you eating right, we don't want you stressing out about COVID, we don't want you stressing out about MS. That's why we look for the treatments that don't have that much of an issue in tolerability, that you can kind of do and forget about. So we want you living as normal of life as you can, and that's the moral of the story, as much as we can kind of emphasize.
Awesome. Thank you, Dr. Alvarez. That's a perfect place to end. We've had a couple of comments of people just saying thanks for taking the time to explain this, and we appreciate your time. I know you've done this for us a few times now. So thanks, and have a great day.
No, thank you very much. I think it's, I'm always happy to do this, and as long as things kind of keep changing, and which we know they will, I'm more than happy to keep doing them. So thank you very much for organizing all this, to you, Kelsey, and everybody there at the Rocky Mountain MS Center.